Patella baja is a condition with exceptionally low riding patella bone. Potential causes are congenitally short patella tendon and arthrofibrosis after a surgery or injury. Signs and symptoms include decreased range of motion, decreased patella glide, decreased tibiofemoral flexion, decreased quadriceps strength, and increased compressive patellofemoral forces when the knee is flexed. Patella alta refers to an abnormal high patella in relation to the femur. Potential causes are congenital long patella tendon and a history of dislocated kneecap. Signs and symptoms include pain in the patella portion, increased mobility, decreased quadriceps strength, and increased patellofemoral compressive forces when the knee is flexed.
Start by having the patient lie supine on the table. The examiner measures the distance between the superior pole of the patella to the inferior pole of the patella. The examiner next measures the distance between the inferior pole of the patella and the tibial tubercle. A ratio is taken between the first and second measurements. A ratio of greater than 1 indicates patella baja, while a ratio of less than 1 indicates patella alta.
Patellofemoral instability can be subtle, resulting in subluxations or dramatic, resulting in dislocations. A patellar subluxation's onset is recurrent. The mechanisms of injury are during extension of the knee, change of direction, or an eccentric contraction of the quadricep group within the last 30 degrees of the range of motion. The patient reports of pain and the knee giving out. Patellar dislocation is present with an acute onset. The mechanisms of injury are valgus blows to the knee or rapid change of direction with the foot fixed. The patient is unable to actively extend the knee or bear weight while the patella is dislocated.
Start with the subject lying supine with both knees fully extended. The examiner stands opposite the involved side and places both thumbs on the medial border of the patella being tested. The subject must remain relaxed with no quadriceps contraction while the examiner gently pushes the patella laterally. If the subject is apprehensive to this movement or contracts the quadriceps muscle to protect against subluxation, the test is indicative of patellar subluxation or dislocation.
Knee effusion occurs when excess fluid accumulates in or around the knee joint. The rapid onset of effusion suggests a tear of one of the knee's major ligaments or a fracture of the knee's articular surfaces. More slowly forming edema is indicative of a meniscal tear, inflammatory conditions, or a less significant ligamentous sprain. Effusion is definitively identified by MRI, but also may be identified by a patient's self-report via the sleep test and the palatable patella test.
Start with the patient lying supine with both knees fully extended. The examiner then stands with the proximal hand over the suprapatellar pouch and the distal hand over the patella. Compress the suprapatellar pouch with the proximal hand, then compress the patella into the femur. Downward movement of the patella followed by a rebound will give the appearance of a floating or volatile patella and is indicative of moderate to severe joint effusion.
Intracapsular swelling occurs when excess fluid accumulates in or around the knee. Signs and symptoms of intracapsular swelling depend on the cause of excess fluid buildup in the knee joint. With osteoarthritis, pain occurs when bearing weight. The pain typically subsides with rest and relaxation. Other signs and symptoms include one knee may appear larger than the other, and puffiness around the bony parts of the knee appear prominent when compared with the other knee. When the knee joint contains excess fluid, it may become difficult to bend or straighten the knee in certain cases. If an individual has injured his or her knee, he or she may note bruising on the front, sides, or rear of the knee. Bearing weight on the knee joint may be impossible and the pain may be unbearable. Causes of the swelling can include arthritis, injury to the ligaments of the knee, or an accident after which the body's natural reaction is to surround the knee with protective synovial fluid. To test for intracapsular swelling, the special test used is the sweep test.
Start with having the patient lie supine with both legs fully extended. The examiner then places both hands on the medial aspect of the patella. The examiner attempts to milk or sweep away any intracapsular swelling by applying pressure to the proximal, distal, and lateral aspects of the patella. Fluid that accumulates on the medial aspect of the patella is representative of intercapsular swelling.
A meniscal tear is present with an acute onset, and the mechanism of injury is tibial rotation, often in combination with knee flexion and/or varus or valgus stress. The patient complains of pain along the medial or lateral going line with possible posterior knee pain and reports of the knee giving out and/or clicking. The patient may complain of clicking or locking during activity in the presence of a chronic tear.
Start with the patient lying supine. The examiner stands next to the involved side and holds the subject's foot. The examiner's other hand is placed over the joint line of the knee. The examiner passively flexes the subject's hip and knee maximally and then applies a circular motion with the tibia, rotating the tibia clockwise and counterclockwise. Pain, grinding, or clicking is indicative of a meniscal tear. Start with the patient lying supine. The examiner stands next to the involved side and cups the subject's foot in one hand. The examiner's other hand may be placed over the joint line of the knee. The examiner passively flexes the subject's knee and then allows the knee to passively fall into extension. A rubbery end feel or springy block is indicative of a meniscal tear.
Chondromalacia patella is a condition in which the cartilage cushioning the area under the patella begins to deteriorate and wear out. Due to this, the kneecap may start to rub against the femur and cause discomfort or pain. This condition is often common among teenagers and young adults, usually affecting women more than men. The condition can also occur in adults who are suffering from arthritis of the knee. Causes of chondromalacia patella include overuse of the knee, arthritis of the knee, imbalance of thigh muscles surrounding the knee, and alignment problems with the knee. In the case of improper knee alignment, resting will not be enough and physiotherapy or surgery may be necessary to correct it. Signs and symptoms of chondromalacia patella include pain and swelling around the kneecap, a vague discomfort of the inner knee aggravated by running, jumping, climbing, or descending stairs. Some people with chondromalacia patella may also have a vague sense of tightness or fullness in the knee area, particularly if the knee becomes swollen. Occasionally, if chronic symptoms are ignored, the associated loss of quadriceps muscle strength and bulk may cause the leg to weaken. Special test for chondromalacia patella is known as the patellar grind test, also known as Clark's sign.
Start with having the subject lie supine on the table with both knees extended. The examiner then stands next to the involved side and places the web space of the thumb on the superior border of the patella. The subject is then asked to contract the quadriceps muscles while the examiner applies downward and inferior pressure on the patella. Pain with movement of the patella or an inability to complete the test is indicative of chondromalacia patella.
Iliotibial band syndrome is an overuse injury of the connective tissues that are located on the lateral part of the thigh and knee. It causes pain and tenderness in those areas, especially just above the knee joint. IT band inflammation occurs most often in long-distance runners, bicyclists, and other athletes who repeatedly squat. IT band syndrome may be the result of a combination of issues, including poor training habits, poor flexibility of the muscles, and other mechanical imbalances in the body, especially involving the low back, pelvis, hips, and knees. There can be a predisposition to develop IT band syndrome. Anatomy issues may include a leg length discrepancy, an abnormal tilt to the pelvis, or genuvarum. These situations can cause the IT band to become excessively tight, leading to increased friction when the band crosses back and forth across the femoral epicondyle during activity. Signs and symptoms include pain on the lateral side of the knee and is due to inflammation of the area where the band crosses back and forth at the femoral epicondyle. Initially, there may be a sensation of stinging or needle-like pricks that are often ignored. This can gradually progress to pain every time the heel strikes the ground and finally can become disabling with pain when walking or when going up and down stairs. Special tests for IT band syndrome include Noble's test and Renee's test.
Start with the patient standing up. The examiner stands in the front of the subject and places the thumb over the lateral epicondyle of the involved knee. The subject is instructed to support the body weight on the involved foot and actively flex the knee as if performing a squat. The examiner maintains pressure with the thumb over the lateral epicondyle. If pain is present under the examiner's thumb when the subject's knee is positioned in 30 degrees of flexion, iliotibial band friction syndrome is indicated. Start with the patient lying supine with the knee flexed up to 90 degrees. The examiner stands on the involved side and places the thumb over the lateral epicondyle of the involved knee. The other hand is placed around the subject's ankle. The examiner passively flexes and extends the subject's knee while maintaining pressure over the lateral epicondyle. If pain is present under the examiner's thumb when the subject's knee is positioned in 30 degrees of flexion, ITB friction syndrome is indicated.
Plica syndrome is an irritation of the synovial membrane in the knee. The synovial membrane encloses the knee joint and contains the fluid that keeps the joint lubricated. Plica syndrome results when the synovial lining becomes irritated, typically the result of repetitive friction to the tissue. As a result, this tissue will become thick and painful. Plica syndrome may result from a combination of several different variables, including altered mobility of the kneecap, quadricep or hip muscle tightness, muscle imbalances in the quadriceps, hamstrings, or hip musculature, improper technique with repetitive activities, change in an exercise routine or sport activity, abnormal hip or knee structure, and abnormal hip or knee mechanics. Patients will complain of tenderness to touch, a catching or snapping sensation when bending the knee, dull knee pain at rest, which increases with activities, and tightness in the knee. Signs and symptoms of plica syndrome are anteromedial knee pain, especially over the medial femoral condyle, visible and palpable tender plica, clicking or snapping during knee motion, and going up and down stairs, squatting, and standing after sitting for extended periods.
Start with the patient lying supine with the involved knee extended and relaxed. The examiner stands on the involved side and places the heel of one hand over the lateral border of the patella, with the fingers of that hand positioned over the medial femoral condyle. The examiner's other hand is placed around the subject's ankle and foot. The examiner passively flexes and extends the subject's knee while simultaneously internally rotating the tibia and pushing the patella medially. Pain and or popping over the medial aspect of the knee is indicative of an abnormal plica. Plica bands may be present in asymptomatic and otherwise healthy individuals. Thus, the location of the band will determine whether or not patella tracking will be affected.